Hello, everyone. Thanks for joining. So, can everyone see the share screen? Can everyone see the screen? I can change the setup if it's better.
I can see it,
I can make it the full screen if that's better.
and I also see your face.
But you don't need to see my face. We'll just do
Well,
the.
it's on there. Oh, you're gone. Come back.
Okay, so slideshow. Start from the beginning. There we go. Okay, now we're rocking and rolling. So Venetia is going to actually present. We couldn't figure out how she could share her screen, so Venetia's going to take lead and she'll just tell me when to go to the next screen.
Hi, everybody. So I have prepared this. So what I actually did was created a very basic PowerPoint presentation from there was a person that we know that took the review course, the one that was expensive, and this person was kind enough to share with us all their PowerPoint presentations. So it's pretty immense. And I'm creating some other ones as well that may help us. But I started with medications. I probably should have started from like anatomy and physiology, right? That would probably made a little more sense. But we'll do that one next. But I've created this one the other night on medications associated with chronic kidney disease from all stages. So I'm actually going to go to a different screen and read whatever I have that Christina will be. It's the same one, but she'll be able to follow along. So the first topic was ACEs and ARBs, angiotensin converting, and the ACEs, angiotensin converting enzyme inhibitors, which are your PRILs. They block the conversion of angiotensin 1 to 2, and they lower blood pressure because of their vasodilatation effect, as opposed to the ARBs, which are your sartans.
Hey, Jane.
They actually, pardon me?
Sorry,
Okay.
I forgot to
They actually lower blood pressure by preventing vasoconstriction, which promote kidney protection by reducing albuminuria and reducing pressure in the glomerulus, excuse me, which helps by reducing that pressure, prevents the protein from leaking. It also aids in improved cardiac output. Some important factors about ACEs and ARBs. Angioedema is what you'll see as a side effect. Chronic cough can happen. I'm sure we've all seen that one with the ACEs, which, if I remember right, it's the bradykinin buildup in the lungs, which causes this cough. And the patients are usually switched to the ARB therapy, and then it goes away within a few weeks. Some takeaways that you'll notice is whenever the doc starts these types of medicines, they'll have a patient maybe in a week or 10 days get a repeat renal function panel to check that potassium. These medicines can cause acute kidney injury if the patient is volume depleted or if they have bilateral renal artery stenosis. It can be used if patients just have unilateral renal artery stenosis. And of course, these medicines are contraindicated in pregnancy if the person is depleted, volume depleted, or if they have severe liver cirrhosis. Diuretics. So the 5 most common types of diuretics you'll see in CKD patients are the 5 listed. And loop diuretics mainly work in the loop of Henle. And I think that was one of the questions that I came across in the rapid, all the different question or the practice questions that I took. I think I remember that one. So the loop of Henle. Let's see here what I wrote was important here. It's saying that it's higher doses for nephrotic range proteinuria, but I also have seen higher doses just in more advanced CKD as well, besides just nephrotic range proteinuria. They can cause hypokalemia, hypocalcemia, hyperuricemia, and hypomagnesemia. The ones we mostly see are the hypokalemia. This one can cause acute interstitial nephritis, and these are the drug classes: the furosemide, Bumex, torsemide, and the ethacrynic acid, which I haven't seen too often. The aldosterone antagonists, which include the spironolactone and eplerenone. Sorry about that. You'll see these ones in heart failure. I've seen these ones in liver disease patients as well. Some adverse effects would be hyperkalemia, specifically for spironolactone. You'll see menstrual changes and gynecomastia in male patients. The nonsteroidal mineralocorticoid receptor antagonists, finerenone, this had its own special little slide in that presentation, just because it's a relatively new one that was just currently recommended by KDIGO. Inhibits mineralocorticoids like aldosterone and cortisol, possibly leading to reducing inflammation and fibrosis in both the heart and the kidneys. Has a potential advantage over other MR antagonists because of its selectivity and more favorable adverse effect profile. The risk of hyperkalemia is lower than with spironolactone, and it does not have the risks like gynecomastia. On to thiazide-like diuretics. These ones work in the distal convoluted tubules by inhibiting water and sodium reabsorption. And I also remember that question as well. The thiazide are hydrochlorothiazide, chlorthalidone, and the thiazide-like are metallazone and indapamide. And the side effect profile is listed right there. Continuation of the thiazide and thiazide-like diuretics. I remember they're generally not used in stages 4 and 5, but metolazone use continues in stages 4 and 5. So you'll mostly see it in the earlier CKD as far as the thiazide diuretics, but they'll typically come off by the time they hit end stage renal disease. Also, a side effect is acute interstitial nephritis. Some potassium-sparing diuretics. They increase reabsorption of potassium and excretion of water and sodium in the distal tubules and collecting ducts. Amiloride and triamterene. They are less diuresis than the thiazides and the loops, and they can also cause hyperkalemia, hyponatremia, and metabolic alkalosis. Not typically seen too much in ESRD, obviously. The carbonic anhydrase inhibitors. I've seen the acetazolamide sometimes with people that have glaucoma or a severe type of glaucoma. They decrease bicarbonate and sodium reabsorption and increase secretion of hydrogen ions. So used to treat edema and metabolic alkalosis. So obviously we won't see that one too often in ESRD patients. Also can be cause if patients are allergic to sulfa, they'll also be allergic to this one. Moving on to beta blockers, 3 different types, beta 1, beta 2, and beta 3. You'll see them with hypertension, tachycardia, MI, coronary artery disease, and cardiac arrhythmias. Those are your ones that end in OL. There's non-selective, the binds the B1 and B2. Those are the propranolol, carvedilol. And then you have the B1 selective, which is atenolol, metoprolol. How they help is by decreasing cardiac output, and renin will cause bradycardia, fatigue, hypotension, insomnia, bronchospasm with the use of the non-selective beta blocker. I think I remember it was beta 1 is heart, beta 2 is the lung. So like 1 heart, 2 lungs. So you know where the beta blockers will affect. That's a little hint. I remember that one actually from the NP state board. So also a question from the boards for NP was, it can mask hypoglycemia and those with diabetes mellitus. So I wouldn't be surprised if that was a question, since they specifically mention it in their review course for beta blockers. Calcium channel blockers, the hydropyridines and the non-dihydropyridines. And the way I remember that one is the pyridines are the one, the amlodipines, they end in the pines, and the nons are the verapamil and diltiazem that don't, the non-pine word. They also have some kidney protection by reducing GFR by dilating the blood vessels going to the glomeruli. So it also helps to reduce albumin in the urine. There are some cautions with the non-dihydropyridines as far as cardiac goes. The dihydropyridines, the long-acting ones are more preferred. Your direct vasodilators, minoxidil, hydralazine, increases cardiac output, plasma volume, and renin activity. Adverse effects are fluid retention, peripheral edema, and palpitations, and can cause hirsutism with minoxidil, which may or may not be a good benefit for some patients. Your centrally acting sympatholytic drugs lower blood pressure by targeted activation of the sympathetic nervous system, causing a decreased arteriolar vasoconstriction. The clonidine is the most recognizable one. It is true, you have to avoid sudden discontinuation of that one, or they'll have a sudden rebound hypertension. And then some benefits, clonidine is available in patch. Avoid with heart block, bradycardia, and methyl-dopa can be used for treating hypertension in pregnancy. So interesting. Alpha receptor blockers decrease vasoconstriction in the arteries, blocking norepinephrine and epinephrine. Your zosins, they can cause peripheral edema. Orthostatic blood pressure is pretty significant, especially when they first start the medicine. You'll see these ones most often taken in the evenings, and they can help by improving urinary blood flow because they are treatments for BPH. On to phosphate binders. They work in the GI tract, excretion of phosphorus in the feces. Side effects include constipation, bloating, and nausea. There was a section about aluminum-based, but I rarely ever see aluminum-based. I don't know what you guys think, but unless they're trying to purge somebody of some sudden severe increase in phosphorus, and they're just used for a short period of time. I never see aluminum-based binders any longer. There's calcium and then non-calcium based. Let's see. Calcium-based binders can contribute to hypercalcemia. And whenever they take their binders, they need to separate their other medicines as it can bind the therapeutic effects of their other medicines as well. I copied and pasted this. They had this list of the generic and the brand phosphorus binders. I just wasn't skilled enough to be able to get rid of this red line or the highlight of the ferric citrate, so just ignore that. But there is a nice little list of the phosphorus binders. The new drug class is the phosphate absorption inhibitor, the tenapanor. I think Anna had some recent educational dinners on Exfosa. And this one is different. It's not considered a binder. It actually works in the GI tract. We actually trialed multiple patients, and the majority, there were a couple of them that had to come off it just because of how profound their diarrhea was. But diarrhea is a common side effect. And Christina and I actually attended this education, and they said after a couple of weeks that it does resolve, but it can be just profound and intolerable for some patients. The vitamin D analogs. With diminishing renal function, the body now has a decreased ability to convert vitamin D from the inactive to the active form. The liver also plays a role in converting vitamin D from the inactive to the active form. Active form of vitamin D does bind to the intestines, bone, and kidney vitamin D receptors, aiding in increasing serum calcium levels. With the increased serum calcium levels, intact PTH levels should normally decrease. Your inactive vitamin D, cholecalciferol and ergocalciferol, and then your active ones are your calcitriol, the doxycalciferol, and the paracalciferol. Continuation for vitamin D analogs, they increase both calcium and phosphate, which is more common in calcitriol. And says before initiating vitamin D analogs, phosphorus levels should be near normal, which I feel like they still start vitamin Ds even with moderately higher levels. With hypercalcemia, you should decrease the dose or discontinue, and do not use if the PTH is less than 100 due to the risk of adynamic bone disease. The calcimimetics, which would be our Sensipar, decreases intact PTH by basically tricking the parathyroid gland to think the calcium is higher than it actually is. Indicated for the treatment of secondary hyperparathyroidism and primary hyperparathyroidism. The etocalcetide is an IV form of this. So your IV patients, or I'm sorry, HD patients can get this. It is highly dialysable, so it needs to be given at the end or right after dialysis. For iron therapy, let's see, consideration for oral iron therapy to treat anemia for 1 to 3 months when the TSAT is less than 30% or the ferritin is less than 500. And I would say a big takeaway is evaluate before treating for other causes of anemia, like besides CKD, like GI bleed or neoplasm. Consideration to avoid use of IV iron in cases of active infection. And for IV dextran, they are still saying to monitor the patient, especially after the first dose. For ESAs, we are all very familiar with our ESAs. In CKD patients, they start them if the hemoglobin goes less than 10, and the target is 11, around 11. We're always worried about our cardiovascular events, CVA, if they're getting higher doses and their hemoglobin is greater than 11. It talks about dosing frequencies. I feel like this is, even though this is the recommended per the guidelines, I still think this is something a provider might have a few tweaks and be a little bit different. So these guidelines could vary a bit based on the provider. Avoid use with uncontrolled blood pressure and certain cancers. Something a little newer for me was the pure red cell aplasia, which can occur in ESA use greater than 8 weeks. It's an antibody-mediated response against erythropoietin, and some things for us to be aware of. If there's a sudden rapid decrease in their hemoglobin, like 0.5 to 1 gram per deciliter per week, they still have normal platelets, white blood cells, and the reticulocyte count is less than 10,000. And then consider the recommendation was to discontinue the ESA therapy. There is the HIF-PHI, the hypoxia-inducible factor. We have one patient that we just started on this product, but this is the oral form of the erythropoietin stimulation. There's also besides the daprovustat, I think there's one it's the vaduvustat, and I think there's a third one as well. But these are oral forms of ESAs. It's metabolized by the liver, so hepatic dosing would be necessary for those patients. Black box warning is similar to the same warning for any ESAs. It was about the same, I think I read the studies on this, it was about the same as our regular ESAs, or just maybe a smidge higher as far as the clotting, the thrombosis. Emergency treatment for hyperkalemia. You'll see this. Acute nurses are very familiar with this. Maybe chronic uses or chronic nurses might not have had the opportunity to see this regimen of therapy. But if a patient is admitted to the ER, severe hyperkalemia, they'll get the calcium gluconate, which it doesn't treat hyperkalemia if they have EKG changes, but it does stabilize the cardiac membrane. And that was a question that we did have on one of our tests, one of our questions in the core curriculum. They'll give them IV insulin and glucose. They'll give them sodium bicarbonate and the beta 2 agonists as well, which is the inhalers, nebulized albuterol. The potassium binding resins are something we mostly see in chronics as well. They bind potassium in the gut, promoting its fecal excretion. Kayexalate is discontinued, but there is still sodium polystyrene sulfonate, and that is oral or rectally. Onset is a little slower, takes hours to work. Veltassa, an oral powder mixed in water, binds potassium, exchanges the calcium, binds potassium in exchange for calcium in the GI tract. Also somewhat slower, so it's more used for chronic hyperkalemia management. It can also bind with other medicines. And Lokelma is a faster acting one. It has a rapid onset within an hour. can be used for both acute or chronic hyperkalemia, which could be a good test question, I think, which one would be the most rapid acting, and that would be the Lokelma. Pain meds for CKD in relation to CKD patients. I mean, NSAIDs we all know are avoided. They inhibit prostaglandin synthesis in the kidneys, and prostaglandins help dilate that afferent arteriole and maintain good renal blood flow. So basically, it just constricts blood flow to the glomerulus. So not a good thing. So Tylenol is the safe alternative, but it's dosed lower in CKD patients. So that's 3 grams a day recommended for CKD. Morphine, oxycodone, codeine, and tramadol. They have active metabolites that are renally excreted, and these products can accumulate. So they should have reduced doses of this product. Believe it or not, Dilaudid and fentanyl are safer alternatives in severe renal impairment because these metabolites are less active and not significantly cleared by the kidneys. And Demerol is strictly avoided, highly neurotoxic metabolite, can cause severe CNS excitation, causing tremors, agitation, and seizures. And that is my down and dirty, quick module about medicines for CKD patients. If any of you guys want to use that as a study guide, just, I mean, obviously you can make it your own, make your own flashcards, put little notes on it. And then Christina can email it to you, and then you can make it your own. Does anybody have any questions?
Thank you, Venetia. And in the chat, Richie says thank you for the review.
Oh yeah, sure. I mean, I'm not a prof. I'm just kind of getting, maybe by the end of this, I'll be really good at it. But I'm excited to do this study with you guys. So I think anything to help us increase our, not just increase our knowledge base, but help us pass this test first and foremost, which is our goal for this. I'm here for you.
And I got your emails. I put in the chat to email me if you wanted the slides. I got the ones you wanted. I got your email, so I will get those sent out after the class. If someone else wants it that's not able to get on tonight, you can reach out to me through WhatsApp and let me know, or you can email me as well. But we have the slides, so we're more than welcome to share with you. I just won't put them on the Anna forum. So going forward, just to let you know, we do have one of the authors of the core curriculum is actually going to present to us in September. And she actually suggested that I attempt to get a CE for that program. So I'm going to deep dive in there and figure that out. So we can get a CE from that when she presents as well. Does anybody have any questions or any thoughts right now? Okay, so next week, I think Venetia and I are going to do another presentation because we do not have a speaker next week. So if you guys have any thoughts on ideas on what you would like for us to present, please reach out to us and let us know. We can definitely work on that. Otherwise, we're going to, once in a while, we'll have like Jeopardy night with questions and things like that as well to make it a little fun to learn. But like I said, if you guys have any questions or want to do something different, please reach out to us. We're doing this for all of us so we can pass this test. I appreciate everyone that was on tonight. I know everyone's got a life and taking the time to sit here and study after working all day. And Venetia, I really appreciate your time putting this presentation together. And I know you're already starting on other ones, so I really appreciate you doing all that.
No problem. Yeah, any input would be appreciated. I want to tailor this to all of us and what we think we need and suggestions. So everybody's thoughts are welcome.
Well, if anyone doesn't have any more questions or concerns, I'm going to close out for tonight and I'll get those slides sent to the ones who reached out to me through chat. Oh, the first one, yeah. Let me figure that out. Hold on just a minute. Um, okay. Let me figure out how to share the screen again. Just give me a minute. Let's see. Give me a minute. Sorry. Here we go. Mm. Sorry, guys. Still trying to figure out all this out.
Well, those were the first couple. Nero, which ones did you want to see the aces and arbs?
I was looking for the one with the calcium gluconate being the reversal agent for
Oh, that's on the very end.
yeah.
Those are the last few slides.
That one?
That's it. That's that one.
Okay.
All right. Thank you so much. I appreciate it.
Not a problem. All right. Anything else? Anybody? Okay, well, again, thank you for joining us tonight, and I will get these slides to you right after our meeting. Have a great night, everybody, and we'll see you next week.
Bye.
Bye.